So our first question is going to be handled by JoAnne, and it's a back to basics question on radiology. Can you elaborate and give tips on radiology coding?
The diagnostic radiology does include many services, and these services can include your basic plain film x-rays, diagnostic ultrasounds, CAT scans, MRIs, mammographies, diagnostic nuclear medicine, and PET scans. When a coder is coding for radiology, specific information has to be provided to the coder. We want to know the name of the study that was performed, and you want to pay attention to the number of views or sequences. So, for example, if a doctor does a radiological exam on the hand and it's only 2 views, you want to make sure you pick that CPT code because there's one, for 3 views and so forth. So you want to make sure that that matches up. And then, of course, the reason for the exam being medical necessity, and the findings, impressions, or conclusions of the findings is the definitive diagnosis, basically, which you would link to the radiology procedure. And then, of course, the provider's signature must be on there. And if there are any plain films or any printouts of the diagnostic studies, that would be copied into the electronic medical record to have the coder be able to pick out exactly what was performed. But the most important facet of the radiology is understanding the global, professional, and technical components, because most radiology procedures include both a technical and a professional component, and coders need to know when to report these technical, professional, and global services. This is not so challenging once a coder is established in a particular healthcare establishment, because if you work for a hospital, you'll know what you have to do. If you work for a physician's group that has the equipment and does everything, you'll know how to bill. For me, years ago, I worked for a mobile diagnostic ultrasound lab, and they strictly did the technical component. And when you bill for a technical component, that's the most expensive portion of the CPT or the bill for the billing. And so, for example, if I did a 76801, an ultrasound of the pregnant uterus, real time, with image documentation, fetal and maternal evaluation, as a technical component, which is what I did, I would bill the 76801 with the modifier TC, meaning technical component. And approximately, give or take the type of test, $353 would be a reimbursement. Now, when we get that information and it's provided to the radiologist, they interpret all of that, and that is considered the professional component, and they do a write-up which is presented to the doctor, and their reimbursement is much less. Now, if you go to a medical practice, like I said, that has the equipment, and they actually do the technical and they do the interpretation, supervision, you don't need a modifier. All you need is the basic CPT code, and then you will get reimbursed for a combination of what the technical and professional is split up as.
So your freestanding radiology clinics would not need a modifier because they own the equipment and they employ the radiologist.
Exactly. So, and really, it can get confusing for patients sometimes when it is split up. It's definitely cleaner when one, like one clinic does it all, so to speak, because they do get confused with, they'll get double bills if there's, co-insurance and things like that, because, well, I already paid this, when it's actually 2 separate things. But the technical component is actually the part that includes the equipment, the supplies, the technician, and any costs related to the performance of the exam. So it's actually the actual performance of the ultrasound that the tech takes. And the only exception to this rule, and this is something that always jumps out at me, especially for people studying for the CPC, that services performed in a hospital, it is assumed that the hospital is billing for the technical component of each study, and that's the facility billing end of it. So hospitals are exempt from reporting modifier TC. So a lot of times when we see coding and you say, like, well, gee, it was done in the hospital, but why am I just using modifier 26? It's because that's the physician component, the interpretation of supervision, but the hospital if it's in a hospital setting, they take care of the technical. And as far as the professional component, it includes the physician work in providing a dictated report or interpretation, or dictated report in supervision. And to report only the physician portion of the service, you would append the modifier 26, saying it's a professional component. And that should be in the first slot of the modifier in the event other x-rays were taken in different parts of the body. You want to make sure that that's the first sequenced modifier at all times. And again, the global service just takes in all of that, both the taking of the x-ray or whatever, as well as the interpretation. And so that's very important. And of course, again, you match the number of radiology views provided and match it to the CPT code. When you're reading notes, you want to know the difference between a scout view and contrast studies, and that's really big. A scout view is a preliminary image obtained prior to performing the major portion of a study. It may be referred to as a KUB, which is kidney, ureters, and bladder. The physician has to document that that film was taken, and he must dictate any findings from the film separately. But understanding a single contrast study, as an example, is when the colon is filled with barium, swallowed by the patient, which outlines the intestine and reveals large abnormalities. And then there's the double contrast in an upper GI series where the colon is first filled with barium, and then the barium is drained out, leaving only a thin layer of barium on the wall of the colon. The colon is then filled with air, and this provides a detailed view of the inner surface of the colon, making it easier to see narrowed areas known as strictures, diverticula, or inflammation. And that's all relative to, when you see the name of the study and then you see what's been done, that's how you find your actual CPT codes. And the exam has to be complete. All documentation must be complete. It must be indicated as complete. And there are certain studies that have additional strict documentation requirements to code for a complete exam. And you can get that on the Medicare website, or you can Google any insurance company, or just plain Google it if you have to. And you'll get the information that's required. That's pretty standard. One of the questions that seems to be a problem for a lot of people studying for the exam, and even those that are CPCs, is that they get confused with the contrast. If a patient receives some type of a contrast orally or rectally, that does not count as a contrast. And this really happens a lot. So you want to pay attention to the wording. Oral or rectal contrast is not billable as a with contrast study. So to report contrast, the technique section of the dictated report must state with IV or intravenous contrast. So that's really important, because I see that question pop up a lot about CAT scans and oral, ingestion of whatever, and people get it wrong all the time.
Well,
and
it's hard for us because we see in the documentation, it says contrast, so we want to code it with contrast. But the guidelines state that oral and rectal, as far as coding goes, does not count as a study with contrast. So that's just something that you have to commit to memory. You can't even write it in one magic spot in your book like I like to do.
Right. And the last thing is that there are some studies, such as the diagnostic nuclear medicine and the PET studies. When you're billing for those studies do not include the radiopharmaceutical supplies. So hospitals and privately owned nuclear medicine and PET departments should report the radiopharmaceutical kit utilizing the correct supply codes. And I should have put here, you would get that out of the HCPCS manual. And that's very important, because, there are some things that are bundled into a study. However, in this case, these two tests in particular, you can bill for the kit, and that would be in the HCPCS code.
And nuclear medicine supplies are really expensive, and that's why they'll make sure that you're definitely coming in the next day for that study, because you got to open it up and prepare it, and it's like thousands of dollars sometimes.
Yeah, so if the practice is putting that money up front for all these supplies to do this, and then it's not billed out, that's how practices and clinics and such lose money. And basically that's it. But mostly it's the technical, professional, and the global where people get confused, and the contrast for oral, rectal with the CAT scans. That seems to be the biggest issues of all.
Yep.
And that's pretty much it.
Very good. Yeah, so technical, you can think of it like a math equation. Technical plus professional equals global, so, and what gets confusing with hospitals is that they actually use two different bill forms. They use one bill form for technical and the 1500 for professional. So you would think that a hospital, if they employ the radiologist, they could bill global, but they can't because they have to use two different billing forms. So they end up using modifier 26 on a 1500 form for reporting professional services if they were entitled to bill it. A majority of the time radiologists are not employed by the hospital, and the hospital just bills their technical form, their UB, and they're done with it. So and
then the radiologist is separate, and everything is sent to them, and they do the interpretations and write out a report and send it to whoever needs it, and that's where they can bill for the modifier 26, and so basically that's that.
Great, thank you.
Do you need more medical certification training? Go to www.cco.us. And don't forget to subscribe to our YouTube channel for updates.